Good morning and good afternoon to all distinguished professors and colleagues across Asia. Welcome to the ASPCI program. And my name is Jianqiang. I'm a cardiologist from the first affiliated hospital of Harbin Medical University. It's my great honor to host today's event. And today we are very pleased to have so many leading experts to join us for today's webinar. We have Professor Otto, President of Asian Heart Society, President of the World Society of Arrhythmia. Professor Li Yue, Chair of AHS Interventional Cardiology Council, and he's also one of the principal leaders of our hospital. Professor Yao, Vice Chair of AHS Interventional Cardiology Council. He's also the head of cardiology departments at the University of Hong Kong, Shenzhen Hospital. Professor Yahya, Vice Chair of AHS Interventional Cardiology Council, and he's the former president of Indonesia Society of Interventional Cardiology. Professor Dabbas, Vice Chair of AHS Interventional Cardiology Council, and he's the current president of Jordanian Cardiac Society. And Professor Hamdan, he's assistant professor at C10 Hall University, and he's also well-known interventional cardiologist. And Professor Wang Xiao is a member of AHS Interventional Cardiology Council. He's the chief of cardiometabolic departments at Fuwai Hospital. And Professor Gong Yongtai is a member of AHS Interventional Cardiology Council. He's also the head of cardiology departments of our hospital. And also some of my colleagues, Professor Xiao, Professor Li Tiankai, and Professor Wang Dingyu. Thank you so much for joining us. And without further ado, I would like to invite Professor Li Yue to give the opening remarks.
Okay, good afternoon, distinguished Professor Otto, Professor Yao, Professor Yahya, Professor Dabbas, Professor Hamdan, dear experts and colleagues. So firstly, please allow me to extend my warmest welcome to all of you for participating the ASPCI program hosted by the AHS Interventional Cardiology Council. And ASPCI stands for Teaching Rounds and Discussion with Asian Cardiologists on Complex PCI. And this initiative is derived to foster academic exchange where case-based discussions, sharing real-world clinical experience and cutting-edge advancements in complex PCI. And through this platform, we aimed to strengthen regional collaboration and elevate clinical practice standards across Asia. Today's session, we will focus on the management of calcium nodule, an area of growing clinical importance and complexity in interventional cardiology. And recently, we have finished the draft of Asian Heart Society expert consensus on management of calcium nodules, and which is now under revision. And during this session, we will review several challenging calcium nodule PCI clinical cases. And Professor Chaoyang will subsequently deliver a detailed presentation on this expert consensus. And we sincerely welcome and highly appreciate valuable comments and suggestions from all participating experts, which will be instrumental to its further refinement of the expert consensus. And I hope that today's session will offer practical insights and actionable takeaways to inform our daily clinical practice. And I really wish today's meeting a great success. Thank you. Professor Otto, would you like to say something? Professor Otto?
Sorry. Well, good afternoon and good morning to everyone. And first of all, I would like to extend my sincere thanks to Dr. Yu Li for this invitation. And also, I would like to congratulate him on his achievement in the very successful series of educational events, but maybe more importantly on the consensus, the report on the calcified nodules by Asian Heart Society. Well, this is very much important for us to have our own values in Asia, in Asian countries. So again, I would like to thank Dr. Yu Li, who has really led this initiative. And thank you all for coming and joining us today. And I'm sure this would be a very fruitful session. And without further ado, I would like to just leave it to the third chair.
Okay, thank you to both Professor Otto and Professor Li Yue for your nice words. Next, I think we'll move to the academic session. And today we have two outstanding speakers who are going to share their perspectives on the management of calcified nodules. And the first speaker is Professor Xiao. Oh, I'm so sorry. We changed the agenda a little bit. So the first speaker is Professor Wang Xiao. He's chief physician and doctoral supervisor, and now he's the chief of cardiometabolic departments from Fuai Hospital. And today he's going to present a few very challenging cases. So Professor Wang, please.
Thank you, Professor Li. I will share my screen first. Okay, dear Professor Li Yue, Professor Otto, Professor Yu, and experts and colleagues, it's my great honor to join this great events of the ACE and PCI program from AHS. And I will share two cases of calcium nodule management, Rotan or RVL. I'm Wang Xiao from the Cardiometabolic Medical Center from Fuai Hospital. I have no conflict interests. The first patient is a 68 years old patient, has a chest pain for 2 days and have higher CTNI and has normal ejection fraction, but has a segmental wall motion abnormality. Diagnosis is non-STEMI. This is angiography. We can see from the LED, we can show the diffuse calcification by a prominent intraluminal filling defects in the mid-LED. It's a thrombus or calcified nodule. So in this case, intravenous imaging is important. And the right coronary has a normal osteo. This is first we use iris to check what's this. This is the iris pullback. We can see in there, yes. And also we can see from the downside, this is the focal, because the focal calcium nodule is protrusion, and we can see some unstable, maybe it's thrombus, I'm not sure, but it's stable now. We can see in the surface of the calcium nodule, and then after that we can see it's almost normal. It's about 180 degree for the calcium calcification. We can see the still image here. So firstly, we use a 215 balloon, it's 16 ATM. We can see it's not acceptable for the from the angiography. And then we can see after the balloon, then we use a 2.75 by 12 millimeter IVL to post balloon for the calcium nodule. This is after the IVL. We can see from the iris, you can see it's better than and have some hematoma here in the proximal. The lumen is bigger than before. This is still image before IVL and after IVL. We can see in the calcium cases is like here. And then because the 205 millimeter DS is not available to cross the lesion, we use the 225 DS to do, and it's unable to do iris after post-dilatation. This is just before post-dilatation. This is a iris image. So the second case is a 71 years old male patient. She's chest pain after activity for more than 10 days. Risk factor including hypertension and type 2 diabetes and smoking, had normal injection fraction, and has segmental wall motion abnormality in the inferior and posterior walls. The diagnosis is stable angina. This is angiography. We can see in the right coronary has diffuse calcification and by a prominent intraluminal filling defect in the middle RCA. The left coronary, left coronary we can see in the proximal circle, and in the middle circle we can see some filling defects. Also, I think this cathode nodule. This is LED. And first we checked, we want to do the iris for the right coronary. We can see in the in the upside, we can see this is from distal. Sorry, it's a little bit, we can see in the downsides. From outside, from the new consensus from the American, from the AHS, we can see it looks like the type 2B calcium nodule here. We can see it is a distal, and in the calcium nodule case, it's very protrusion and has more than 270 degree. And the Y bias is okay because in the upside and downside also we can see calcification. So firstly, I think it's large and diffuse calcification with calcium nodule. We want to use the rotor first. Because the lumen size, the vessel size is big, it's more than 4 millimeters. So we use a 1.75 millimeter burr at 16, and then we use a 2 millimeter burr. Then we check the iris. We can see, yes, we can see in the calcium nodule case, we can see the reverberation, and also we can see the rotor. Its lumen size is larger than before. Now this is before rotor and after rotor. We can see in the calcium nodule cases. We can see, yes, the lumen looks okay. It's larger than before. And then we use a 2.5 balloon and 3.0 by 18 stent, and post dilation with 3.12 and 3.3 balloon. So this is the final result in the iris. You can check the iris. Here comes the minimal stent area here, and here is calcium nodule position, and it's very, very expanded. So how to solve calcium nodule, rotor, RVL, or other devices? So firstly, I think the identification calcium coronary stenosis has, in the past 10 years, we have used the iris on OCT, have different types of the classification, but actually, usually we need to know some information like the degree, like the superficial or deep, like the length. I think it's the most important, but the calcium nodule is another very big important information. So traditional classification of calcium nodule is erupted calcium nodule with like potential thrombosis, and the protrusion with non-efferent calcium nodule is like the smooth fiber cap overlying protruding calcium mass with a strong signal attenuation. But now in the 2025, Z. Ali proposed the A new CN calcium nodule classification: eruptive calcium nodule is deformable, and non-eruptive calcium nodule non-deformable, and the non-eruptive calcium deformable. And also, I think Professor Tao will show you later, this is a new AHS classification like type 1, type 2A, and type 2B, like this kind. The type 1 is balloon expansion is deformable and has superficial thrombus intact fiber cap. And it's easy, maybe easy, it's soft and easy to expand. And type 2A is also like the full deformable but have protrusion nose thrombus. It's easy to stent expansion, but type 2B is not deformable and risk on the expansion is higher. So this is new. And also we can see after the, we know the calcium nodule calcium scoring by OCT 2025 only has used the traditional like the degree and the calcium thickness and also the calcium length, but not the calcium nodule. So there are some treatment modalities and also have some protocols like the workflow. For the this is also the from the Asia. We can see is in the calcium nodule. Use iris OCT assess calcium is the calcium nodule. We can see usually we use OA or RA, the rota first. Maybe RVL in 3 years ago is only investigational. But now we can see in the new treatment algorithm in the 2024 from the America, we can see for the long diffuse calcium, with or without natural calcium, we can use like the atherectomy. But if it's concentric, extrinsic, natural calcium, we can use the RVL. So for the two cases I showed, the first case we use RVL is focal, and the second case maybe it's focal but have some diffuse calcium. We use rota. So for treatment technique selection, maybe we can see there's some recommendation from different countries, but actually for the eccentric calcium, the calcium nodule is not as difficult, as also no consensus. Like the eccentric calcium, usually we like to use IVL because rota maybe the white bar is not available, but calcium nodule, firstly, I think the rotational atherectomy, if the white bar is okay, we can recommend first. The IVL is also okay, but it's not the first choice. So other combined special scenario, including the RSR, and also we can use the rotor RVL and the special for the laser. So this is AHS manual algorithm for the C, and we can see for our two cases, maybe it's type 2B non-deformable. As Y bar is okay. For the second case, we use a rota. Y bar is not okay. We use RVL. So in conclusion, RVL is important for identify calcium nodule for the overall calcium distribution, such as Y bars and perforation vessel size to assist in calcium multiplication selection. Rota remains the most common tool for having calcium lesions and for the calcium nodule, and can consider upsizing the bird to 0.6 to 0.7 if the lumen is large. And RVL is most effective against concurrent calcium in balloon crossbar lesions. Sizing should be 1 by 1 with the reference vessel diameter, and more pulses are often required. Prior to standing, perform NC balloon, 1 by 1 balloon dentation, followed by imaging to confirm the present capital fracture is also, I think, is important for the DS plantation after all the preparation. Thank you for your. Thank you.
Okay, thank you so much, Professor Wang, for your very great presentations. I think all the cases you presented today are very challenging. And you also introduced the general strategies when we deal with the calcified lesions, especially the calcified nodules. I'm sure there's so many things we could talk about, but we will have the discussion after the second talk.
Thank you.
So, yeah. And the second speaker is Professor Xiao. He's the Deputy Chief of Cardiology Department, Section 4 of our hospital. And he's a very experienced interventional cardiologist with a lot of experience in the use of intravascular imaging modalities. So today, Professor Xiao is going to take us through the clinical diagnosis and treatment strategies for coronary calcified nodules. Please, Professor Xiao.
Okay, thanks to the introduction of Dr. Li. And I am Dr. Xiao from the first affiliate hospital of Harbin Medical University. And it is great honor for me to have this opportunity to share my topic of today, which is advances and future perspectives in clinical management of coronary artery calcified nodules. First, I want to welcome our close friends, Dr. Otto, Dr. Yahya, and our new friends, Dr. Dabbas and Dr. Hamdan. So today we are going to share our latest version of our consensus on the management of calcified nodules. So I hope that after my talk, our professors can give also an advice and your opinion on our current version of the consensus. First, I think that calcified nodules is not very familiar to us, especially for the interventional doctors. The first identification in the human body of calcified nodule is through the intravascular imaging, which is IVUS. So which means that by angiography only, it is relatively impossible or very hard to make 100% guarantee of the identification of the calcified nodule, because it is relatively hard to distinguish it from the thrombus, filling defect, plaque rupture, etc. So we can see that intravascular imaging is of great importance. And also currently we can see IVUS and OCT are all very effective tools in our clinical usage. So we can see that each of the device has their own advantages. For example, the penetration of the IVUS is good, it's better. However, the resolution of OCT is better. So sometimes relatively it doesn't can replace each other. So each of the device can used to make the identification and of the calcified nodule. However, currently the clinically subclassification of the calcified nodule still depends on the OCT, with a relatively high resolution. So from this image, we can see this is a typical calcified nodule that scanned at the proximal part of the RCA, and we can see there is a superficial calcification which is protruding into the lumen, and also the minimum lumen area is relatively small, and this is a very typical image of the calcified nodule by IVUS. And we all know that calcified nodule is, how to say, the prevalence is around 0.8 to about 8% or something. It depends on the different kind of clinical cohort of the patient. For example, it's relatively higher in the population of the ACS patient. And also we can see it's relatively often seen in the proximal part of RCA and also the bifurcation part of the left main, especially the proximal part of RAD, which is more often detected in these kind of locations. Still, we do not know why. When we talk about the formation or the mechanism of the calcified nodule, currently we do not have a very confirmed explanation for its formation. Some experts try to explain its formation, especially the eruptive ones, using this kind of a hinge motion mechanism. For example, when the coronary artery is at a very sharp angle, especially when the heart is moved during the systolic and the systolic and diastolic phase of the heart, this kind of calcium sheets is highly likely to be shattered during this kind of hinge motion effect. And then this kind of small pieces of calcium may be protruded into the lumen and also damage the intima, causing an immature situation of this kind of composition plaque with protruding the calcium, which could be a potential explanation of the mechanism of the formation of the eruptive calcified nodule. When we talk about the calcified nodule, why do we pay so much attention on it? One of the reasons is that the natural history and also the prognosis after PCI of the calcified nodule is poor. So that's why we care about it so much. Before we cared about the plaque rupture and the erosion a lot, because we know all know that they are very familiar cause of the ACS event. However, currently we can see that calcium nodule is still a very important cause of the ACS events. And what's more, during the follow-up, we can see the calcium nodule, especially the eruptive ones. This is a relatively very early published paper. The explanation of the eruptive ones is calcium nodule with disruption of the superficial intima fibrous layer. We can see the miss events of this kind of calcium nodule is relatively high if you do not treat it. However, if you treat it with PCI, for example, following our guidelines of the current PCI guidelines, we make full expansion of the stents. For example, in the patient of the calcium nodule group, we can see it's still associated with relatively high events of reappearance of calcium nodule, which means that the calcium is highly likely to be regrowth and protruding into the vessel lumen through the stent struts. This is also one of the most highly likely explanation for the stent failure or target lesion failure for the cases with calcium nodule after we put a stent in. One of the very interesting spots about calcium nodule is that we all know eruptive ones are associated with relatively better stent expansion rates compared to that of non-eruptive ones. However, the prognosis is poor due to the relatively very high in-stent restenosis rate for the eruptive ones. So this is why our group and Professor Li wants to raise this consensus. So we are trying our best to collect our experience and our suggestions at the current spot without any large prospective RCTs, and to give our some flowchart or guidelines to how to treat it. We all know that based on the OCT, we can divide the calcium nodule into two subtypes, which is eruptive ones and non-eruptive ones. The eruptive ones is associated with relatively in-smooth intima. For example, the protruding into the vessel lumen and also maybe some stromas on the surface, a lot of attenuation behind. And this kind of eruptive ones is relatively deformable. So we can see that it's usually easy to be dilated by the balloon only, and also the stent expansion is relatively high, although the target lesion failure rate is high. However, in the non-eruptive ones, 1/3 of the non-eruptive ones, according to the retrospective analysis, we can see that it's relatively non-deformable, or it's hard to be dilated with a balloon only. So we can see that the non-eruptive ones, some of them is associated with relatively high risk of underexpansion. So this is why we want to divide the non-eruptive ones into two subtypes, the type 2A and type 2B in our consensus. Currently, there is no clear ways or guidelines how to treat these ones. The reason is that we do not have the clear answer to this one. We have no large prospective clinical studies to tell you which kind of device is relatively good to use, and also a promise to the good prognosis. So this is why I think it's a good reason to talk about it. Thanks to the help of Professor Otto, Dr. Yahya, and also other professors to join our earlier work of this consensus. You gave us a lot of great opinions. So next, I want to share some comments from our reviewers of our journals. This is a highlights of our consensus. It's 4 topics. One is the great importance of intravascular imaging. I think this is of no we all agree with this one, that intravascular imaging is of great importance in the identification of the calcium nodule, and also during the whole procedure of the stent optimization to guide the calcium nodule management. And also wear bias is of great importance when we are trying to use a debulking device when we treat a calcium nodule. So intravascular imaging currently is the only strategy to tell you the wear bias situation, and also can give you a lot of details. Later we will talk about this, how to treat it. The third one is plaque modification. I think this is of one of the most important part in our consensus, how to deal with how to make the plaque modification for the de novo range of the capsule nodule according to the different subtypes of the capsule nodule. Here we involve we all seen that Dr. Wang also showed some published papers that 1:1 NC balloon according to the lesion out to the lumen vessel is of great importance at this spot. We can see that before we after we confirm the existence of the capsule nodule, we try to use 1:1 NC balloon. You can combine with a cutting balloon or scoring balloon, but finally we use 1:1 NC balloon to try to dilate this kind of capsule nodule. This means that we try its deformability, whether this kind of lesion can be fully expanded through the 1:1 NC balloon or not. I think this is of great importance for the promise of the good stent expansion later. If we do not perform this one, it's hard to distinguish which of the non-eruptive capsule nodule is deformable or not. And after this one, we can divide the non-eruptive capsule nodule to type 2A and type 2B, these kind of two subtypes. And later, if the non-deformable capsule nodule cannot be fully opened through the 1:1 NC balloon, we try to use a more aggressive plaque modification strategies. For example, the debulking strategies like ROTA, orbital extractomy, ELICA, etc. And if this kind of strategy failed, we try to combine use the IVL system to try to shatter the capsule nodule. So this is a main theory and our idea to treat the capsule nodule. About the capsule nodule related instant restenosis is I mean, great headache to us, especially for the recurrent of the capsule nodule related instant restenosis. So our solution for this one is a sequential plaque modification, which means that we suggest the surgeons, the operators, to try to use at least two kind of debulking strategies. For example, you can use the rota lithotripsy, for example, rota combined with IVL or ELICA, according to what kind of device we have in your cath lab, and try to modify the plaque, and then use DCB as suggested over the DS for the capsule nodule related instant restenosis. And this is a consensus development methodology and evidence level. So our reviewer indicated that majority of our suggestions or our suggestions to the reader is that there is no large clinical trials, no evidence to tell you why do we suggest it. So we can see that according to the consensus from the ECS, we can see level 1. Level of evidence 1, 2, 3, and 4 is according to the RCTs, observational studies, or case series, or level 4 is expert opinion. So we cleared our suggestions at different part according listed very detailed. This kind of suggestion is according to what kind of evidence level. And this is the relatively flow chart how to treat the capsule nodule, especially to different kind of subtypes. I just explained that according to the different kind of deformability of the capsule nodule, especially the non-eruptive ones, the treatment is different. And also this kind of a subclassification of capsule nodule is different from the eruptive and the non-eruptive ones, which means that before we only depended on the OCT, intravascular imaging. Now that type 2A and type 2B is combined with, it's not precise, but we can see the functional performance or ability of the capsule nodule, whether it's deformable or not. Sadly, this kind of information cannot be picked up from the intravascular imaging. From OCT or IVUS, you cannot tell this capsule nodule is deformable or not. So we combine the OCT and this kind of a relatively functional examination to tell you which kind of subclassification of the capsule nodule is. And also according to this kind of information, we guide the following procedures of the treatment. And This table has been shown by Professor Wang Xiao that showing the details of and also how we make the subclassification of the calcium nodules. And this is another part that we also added a new chart by the reviewer comments. We can see that according to the different kind of situation, you can use different kind of intravascular imaging to make this kind of diagnosis or subclassification of the calcium nodule, because sometimes in the facility you do not have OCT. Of course, it is okay to use IVUS, because still you can make more precisely identification of the calcium nodule compared to the angiography. And also we concerns there is some concerns by our reviewer comments about the special population management. For example, some patients has the potential risk of kidney disease after using the OCT, and also some patients with diabetes mellitus, also a higher risk of potential damage to the kidney. So here's our new chart about the special population management. For this kind of patient with potential risk of damage to the kidney, we can use IVUS. It is okay. And also there is some ways, for example, before or after you use the contrast, you can do something, for example, some stay hydrated to reduce the risk of kidney injury. We just mentioned that when you are trying to use a debulking device, the whereabouts position is relatively very important. This is a courtesy from Dr. Kashima, and he also participate in our consensus that he raised some ways to try to adjust the whereabouts. This is also a very important part in our flow chart. If you detect the whereabouts is not so favorable, you can use the following ways to try to make whereabouts adjustment to make it favorable for the following rotablation or ELECA, etc. I believe this is relatively the most important part of our consensus. This is a flow chart. I mean, at least currently, this is our best, form to tell you how to do it. First, after identification, which means confirmation of the calcium nodule by OCT or IVUS, of course, if the imaging catheter cannot pass, you can perform active rota or ELECA to make a channel first and then perform the intravascular imaging. And when you identify the calcium nodule, you can try to use the cutting balloon or scoring balloon. Of course, it is majority of the time it's 0.5 millimeter smaller compared to the vessel size, and then combined with 1:1 NC balloon to try to dilate this lesion with calcium nodule to examine whether this kind of calcium nodule could or not be fully expanded with 1:1 NC balloon. If this kind of a balloon could be successfully opened, we go to the left part here, the left part, and which means that this kind of lesion could be well expanded, and then no matter it's type 1 calcium nodule, it's a eruptive ones, or it's a type 2A calcium nodule, both of them is deformable. However, it's the characteristics from the OCT or IVUS is different. You can go ahead to use the DES with intravascular imaging optimization to put a stent in. Later, we will explain why we didn't suggest to use DCB for the type 1 NC balloon calcium nodule, even though we know the relatively target lesion failure rate is high in calcium nodule type 1. If the NC balloon could not be well expanded through the 1:1 NC balloon, we go to the right part of this flow chart. So majority of the time, it is time 2B, which means that it's non-deformable, non-eruptive calcium nodules. So first, we evaluate whereabouts situations with the intravascular imaging with IVUS OCT. If the whereabouts is favorable, we go to the rota or orbital or ELECA on the left part. If the whereabouts is poor, we go to the right part. We make whereabouts adjustment. We just mentioned these kind of details. And if the whereabouts is good, after adjustment, we go to the left part, perform rota. If the whereabouts after adjustment still remains poor, we use IVL to treat this lesion. And then we go back to once again evaluate with 1-to-1 NC balloon from 2 different views to evaluate whether this kind of lesion could be fully expanded or not. If yes, we go to the left to make DES with IVI optimization. If not, we try to use the combination plaque modification we just mentioned, like a rotalithotrypsy or elacatripsy, to make a more aggressive plaque modification. And finally, evaluate again. If it is well expanded, we'll go to the DES. If not, we use DCB. So this is the flow chart we are trying to suggest to follow how we treat this kind of CAS technology. And some other topics about the CAS technology related target lesion revascularization, how we treat this kind of lesion. We just mentioned about this part earlier, that we recommended to use the combination debulking strategies, at least to use 2 kind of strategies to make a better plaque modification to reduce the volume of the calcium that regrows into the stent struts. And DCB is the first recommendation for the CAS technology related in-stent restenosis. And the next is a management of long-term follow-up. This is also a part of from the reviewer comments that they suggest us to add this part. How I think the treatment is one thing. Currently, we still don't have the how to say large clinical trials to tell you how to do it. For example, how to modify it, how to treat it. So clinical follow-up is of great importance for this kind of patient. So we make the follow-up for different kind of patient. For example, there are follow-up program for type 1, routine clinical follow-up, and intravascular imaging follow-up, and the clinical evaluation after this one. For the type 2, we still make the plans for the type 2 CAS technology. This is level of evidence by 3. And finally, prevention and intervention of the in-stent CAS technology progression. This is also we just explained earlier. Finally, there is a limitation. We want to emphasize that majority of the content in this consensus is based on the case series report or observational studies. There is no large prospective clinical studies. So I think this is very important to list this kind of information in the limitations. We want to tell you, even though we do not have a very hard and a very sharp answer to this one, we want to try our best to give you the answer, what we're concerned about it, and currently what we can to do with it. I'm not quite sure if you have time, but I have 2 very short cases. One is a 68 years old female. We can see the CTA indicated triple vessel severe calcification, especially RCA. When we perform angiography, we can see the proximal part, especially near the ostium part of RCA, is some filling defect. Seems like thrombus or something. So this is a very good example that CAS technology sometimes doesn't seem to be associated with severe stenosis, or sometimes it's hard to distinguish with thrombus, plaque rupture, etc. So next, we perform IVUS. We can see this is a very representative image of the CAS technology protruding into the lumen in the surface. It's all nodular calcification. So next, we can see the whereabouts. In this case, is relatively, I think, friendly. So it's very close to the CAS technology. So we perform ROTA, use 1.5 burr, make several debulking strategies. After this one, we use cutting balloon and 3.5 1-to-1 NC balloons. I think through the image, we can see it's relatively deformable. The NC balloon opened relatively very well from different views. And when we compare using the IVUS, we can see the after ROTA and cutting, the instant lumen gain is relatively good, especially the third image. When we compare the baseline and after ROTA and cutting, we can see the some part of the superficial calcium has been removed after ROTA. This is why we try to recommend to use ROTA if the whereabouts is favorable. The ROTA ablation is one of the most popular, often used device to reduce, to make the debulking function, to reduce the calcium sheets that are on the superficial of the calcium. So this is a image after cutting and ROTA ablation. And next, we put stenting 3.5 and 4.0 stents with 4.0 NC balloons. This is instant lumen gain. I think this is relatively very good stent expansion. The minimum stent area is over 10 square millimeter. So this is a representative case of eruptive ones that is deformable, and use NC balloons, you can make a relatively good instant result. The second one, we can see the RCA proximal part still. I think this is a very focal stenosis here, the RCA part. It doesn't seem to be filling defect. However, from the IVUS, we can see this is also typical sign of the calcic nodule that protrude into the lumen. However, from the angiography, it seems only to be a eccentric stenosis. And also we perform OCT. Once again, we confirm this is a calcic nodule. We can see it's a very typical image. So next, we use a 1-to-1 NC balloon again from two orthogonal views to make sure that this NC balloon could be well expanded. And following the stent, we put a long stent in. I think it's 3.5 stent. And this is the instant result. Also, once again, confirm that the non-eruptive ones, when you use an NC balloon, makes a 1-to-1 ratio NC balloon to make to dilate this kind of stent calcic nodule, you can test whether it's deformable or not, and at least you can guarantee a very good instant result. So we talked about a lot, and currently what we know eruptive ones is associated with relatively poor prognosis after using an DES, but currently we don't have a very clear answer how to treat it well. What we don't know which kind of specific techniques is associated with a good prognosis, which means lower rate of target renal failure, or even the heart events, for example, the myocardial infarction or cardiac death. However, our flowchart, we try our best to make a reasonable theory how to treat it. There is a lot of papers that indicated the safety and effectiveness of IVL for the calcic nodule, but we still do not know compared to the ROTA, especially when you make an aware adjustment ROTA, whether it's effective or not. Finally, is DCB a good choice for calcic nodule? We don't know. Currently, there is only retrospective multi-center observational studies, but still indicating the DCB for the calcic nodule is not a relatively, better compared to the DES, especially for the patient with a calcic nodule. So we didn't suggest to use DCB. We don't think there is a very, good evidence to make this kind of a recommendation. Another concern we are worrying about is that during the flowchart, I don't think intravascular imaging participates a lot, especially for the whole identification and also the guidelines. We are using the NC balloon. I think this is how to say techniques. Currently, we can give best to test whether it's deformable or not. But the following part I just mentioned, the stent optimization still requires the help of intravascular imaging to make a better stent expansion, especially the edge problem, geography miss, etc., which can make sure the good prognosis of the calcic nodule. This is all I want to share. I think the following time I will give it to Dr. Li Yue, Dr. Otto, especially all the professors online, to give our suggestions and your opinions about our consensus. Thank you. Your time is very important.
Okay, thank you so much to Professor Xiao for your detailed introduction of the consensus and also two very complex cases. I think both Professor Liu's team and all the experts from the AHS Interventional Cardiology Council have put a lot of efforts finishing the draft version of this consensus. And now I think we are open for any comments and questions. So I would like to invite all the panelists and the speakers to give your thoughts on this topic.
Can I have?
Yeah, please.
Hello. Well, Dr. Wang, Dr. Cao, really excellent presentations, and particularly, reflecting the consensus document of Asian Heart Society, which is an excellent document. My question is actually related first of all, of course, now we have had a new tool, DCB, in calcified lesions. As Dr. Xiao mentioned, at the moment we don't really know where we are standing in use of DCBs, but still it looks like, to our experience also in the same direction, that there is a place, there is a niche place for DCBs in selected calcified lesions. But my question is related to the OPN balloons, I mean, very high pressure balloons in the calcified lesions. Would you just elucidate on this, Dr. Xiao?
Dr. Otto, thank you for your, I want to say, sincerely thank you for your contribution to this consensus, because you gave our very valuable comments before. Yes, we think about this kind of a high pressure
langsung aja, Pak.
balloon. And according to the earlier published papers, this kind of a high pressure balloon is I think one kind of scoring balloon or some kind of a balloon based modification strategies to try to treat it. But one thing is that I'm not quite sure in China how to say, widely available this kind of device. This is one thing. Another thing is that really currently there is no, I mean, evidence, for example, the papers to indicate this kind of much higher double layer, higher pressure NC balloon compared to the traditional, I mean, NC balloon has a better kind of dilation or some kind of modification strategies. So we didn't evolve this one because one thing is not quite sure available. Second thing is that there is no clear evidence. But I know it's a new tool, and a lot of professors indicate this is a potential choice. When you modify the plaque, you can try to use this kind of higher NC balloon. So I will consider about your suggestions. So maybe suggest that if you use the 1-to-1 NC balloon, it's hard to dilate. Maybe we could consider this kind of, I mean, high pressure balloons. Professor Otto, thank you.
Thank you.
Yes.
Dr. Hamdan, please.
Yeah, good afternoon, and thank you for this great conference and these great talks. Thanks, Dr. Yang and Dr. Wang. Just a couple of points when it comes to calcium. We know as cardiologists now we have to live with the fact that calcium is there. In one large study, 50% of the people who are above the age of 40 had some sort of calcium, went up to 80% in those patients who are above the age of 60. And we expect more than 90% in patients who are above the age of 70. It's a little more common in males than females. Around 77% of females above the age of 70 do have calcium. I think one of the major issues here is we know that it constitutes around 5% of the acute coronary syndrome. And it's a challenging because many times, often we are faced with it when the patient is on our table. So we really have to be ready. But I think the advent of the coronary CTA is making this a little more easier because now we can have an idea about the lesion, the calcium. We know that the coronary CT will help us in finding the type of the calcification or the plaque, the shape, the volume, the consistency, the size, and the vulnerability of the plaque. And I think with the advent of artificial intelligence, this will help us a lot in studying those kinds of plaques and especially the coronary nodules. And for the new generations, you should expect to have a higher incidence of those in those elderly patients who are on dialysis or they have kidney disease, and of course your diabetic patients. And just to add a little that we consider the coronary nodule as an advanced stage of coronary atherosclerosis, and as Dr. Yang mentioned, we probably the issue doesn't end at the table. We have to really monitor these patients and be very aggressive, especially with the statin treatment. We know that the nightmare of the coronary nodule, especially the eruptive one, I consider it as a malignant form of atherosclerosis is the instant restenosis. It could reach up to 27% because those plaques, they continue to invade a fully expanded stent. So it doesn't end by having a good results at the table compared to maybe 2% for those regular plaques. And the thrombosis is pretty much, could be equivalent to between the two kinds of plaques. And lastly, the target lesion failure, it could go up to 14% compared to 8% to those patients who have non-eruptive plaque. I think, and it has to do with probably the constituency of those plaques. They is they have a hydroxyapatite kind of calcium, which contains calcium and phosphate. I mean, roto is an option, laser is an option, lithotripsy is an option, but a lot of people are coming with combined, what we call rototripsy, where one will debulk and the other will fracture the plaque. And the 2-year probably results were much better than the regular treatment. And, there's also the Arcadia method where you go inside the plaque and you try to like punch holes inside the lumen of the plaque and modify it, so it might make it easier to tackle. Concerning the DCP and the use of DCP, so far it's really inferior to stenting, unless you are encountered with patients who have a high risk of bleeding. But personally, I think the future of cardiology, interventional cardiology, is going to be DCP, and stenting will be just for use as a bailout in case of dissection. Thank you for the chance to participate.
Dr. Hamdan?
Yes.
I'm Wang Xiao. So, Dr. Hamdan, you mentioned coronary CT to check their volume and their structure and calcium. And I think really we can see from CT as another information of calcium density. So because there's a new criteria like from CT criteria, CT score to predict stent expansion. They included the calcium density. As a low density has a higher stent expansion, and a higher density has a lower expansion. I think for the new consensus, we can check like the type 1 capsule nodule maybe have the low density, and the type 2 and the undeformable maybe have higher density. So in the future, I think we can you do a study like that from CT to check, and from the comparable to the IRIS or OCT to check if it's expandable. Thank you.
Thank you.
Any more questions or comments?
Can I comment?
Please.
Yes.
Go ahead.
Thank you very much. I'm Fauzi from Indonesia. Thank you for inviting me. This is a very excellent presentation of calcium nodule. It was very insightful and clinically relevant. So what my role is in managing calcium nodule, it is important to recognize that we are not treating the nodule in isolations, but rather the entire calcium burden within the vessel. So this is important to think what kind of how to manage it well. And calcium nodules are often surrounded by other calcium morphologies, such as calcified plates, eccentric calcium, and protruding calcium, which collectively influence lesion behavior, device delivery, and procedural outcomes. Therefore, a comprehensive approach to calcium modification is essential. So I think the critical first step is to identify the type of calcium nodule. Intracoronary imaging, particularly OCT, plays a key role in this process by differentiating between eruptive and non-eruptive calcium nodules. And this distinction has important therapeutic implications. The other point is how the treatment is not only aimed to relieve ischemia, but also to minimize the risk of acute complications, such as perforations, distal embolization, no reflow, or dissection, which is common in a calcified vessel. And in addition, long-term outcome must be considered, particularly the risk of instant restenosis or reprotrusion of calcium, particularly in the eruptive calcium nodule. Therefore, lesion preparation and device selection become critical. I saw in the first cases that Dr. Xiao Wang, it showed the calcium nodule which unfavorable wire bias, but Dr. Xiao Wang is excellent in treat using IVL. So this particular important to mitigate the risk of perforations. And finally, whether we have to use stent or DCB in this particular situation, especially in eruptive calcium nodule, because if there is a stent failure, it's quite difficult to treat. Calcium nodule stent failure is quite difficult to treat compared with the DCB of failure. And the last is a pharmacologic therapy should be viewed as an integral part of the overall treatment strategy. Thank you very much.
Thank you. I think before we leave, we would like to hear from Dr. Dabbas for his short comment. Dr. Dabbas, please.
Thank you, sir. Thank you very much, all our friends and speakers. It was really an excellent presentation on calcified nodules, highly practical and well-structured and clinically relevant. I particularly appreciated the clear integration between intracoronary imaging and calcium modification strategies, techniques, as well as balanced discussion of intravascular lithotripsy, rotational atherectomy, and orbital atherectomy in these challenging cases. Thank you, very insightful and educational talk on an increasing important and complex topic in cardiology and in intervention. Well done. Thank you.
Thank you. Dr. Lee?
Okay, Professor Yao, any comments?
Yes, thank you, Professor Lee, and all. Great consensus, great presentations. Don't want to spend too much time to compliment everyone, but it's a very great work from everyone. But one thing that I think, given all these experts here, I think Dr. Lee, we should consider to make a registry together to look at some of the important questions that we raised. For example, what are the type of treatment that usually we are giving to the patients? What are the outcome of the patients? And very one important problem that we see as clinician is which are the patients has deformative or non-deformative calcified nodule before we do the pre-dilatation. You know, I think we can consider to have a registry to collect all these cases from all the experts, such that not only we have a consensus, but we will also have a great database to demonstrate the expertise of our group in treating patients with calcified nodules. So this is just my comments, but again, congratulations to all the work and my pleasure to join. Thank you.
Okay, thank you. So any comments from Professor Gong?
It's a very pleasant for me, and I have a question about the calcified nodular plaque modification. For example, if we found the eruptive calcified nodular, as we know, for this type calcified nodular, it will be reproducing after stent implantation. How about we choose as the first to do RE for this type calcified nodular to reduce the reproducing of the lesion after stent implantation.
Okay, thank you, Professor Gong. I think this is of great important when treating the chaos technology. Currently, we know that eruptive ones, chaos technologies, especially the eruptive ones, is associated with relatively poor, prognosis. No matter it's a natural history, you do not treat it, or you treat it with a DES. I think this is the greatest problem. So currently, for the eruptive ones that requires the clinical treatment, which means it's ischemia or the minimum lumen is small. Currently, our idea is that you can see from the flow chart. Yes, we try to use the NC balloon to dilate, because currently, following the guidelines, like Professor Yongtai just mentioned, we don't have answer. Besides a well-expanded stand, what should we do? In our consensus, we didn't mention about the medication because still there is no, evidence besides the very high level of statin therapy, control the cholesterol and the blood glucose. What can we do? So currently, we still, I think one thing is that to identify it. This is two things. One thing is that we know it's a CAF technology. So besides stenting, we are making a very close follow-up for this kind of patient. For the potential target lesion failure or AHS events, we know it is. And besides stenting, we are making full medication a close follow-up. I think this is a great idea. And for the ones that it's hard to dilate, we try to use more aggressive strategies because some experts concerns if you perform rota for the eruptive ones, maybe it's a high risk of slow flow because sometimes there is thrombus on the surface. So this is why we are trying to use the current flow chart to treat it. Still, like I think the majority of our experts, their opinions, we need large clinical trials to give, I think, answers to the majority of the questions. Thank you.
So, Professor Otto, do you have further comments?
Not really, as we are running out of time. I think that we had a very fruitful discussion, and it looks like that we have had now new tools and new approaches to actually improve our practice. I started to use ROTA maybe decades ago, but now we have the improved versions and new really intravascular imaging tools, which really are instrumental.
Professor Otto, we can't hear you.
Wang Xiao教授能听见我们吗？啊，可以啊，能听见，咱们的线路上。
I'm sorry. That has a call from.
I think maybe there's the.
Maybe I dropped. Can you hear me now?
Yeah, we can hear you,
Yes.
Professor Otto. Yeah, please go ahead.
Yes, I don't know where it was interrupted, but just I would like to say that this has been a very fruitful discussion today, and it looks like that we have now improved strategies with new tools. I started to use ROTA some decades ago, but now we have the improved versions and new other tools, balloons, wires, and of course imaging strategies. And now we have realized the importance of the preparation, diagnostics, and preparation of the lesion before any intervention. And now we have the DCBs, and we will see how it will work in long time run. And once again, thank you all, and I'm really honored to be part of important panel. Thank you.
Okay, thank you so much, Professor Otto, for your very great comments. As we are coming to the end of today's event, so finally, I would like to have Professor Yahya to give the closing remarks.
Okay, distinguished Professor Otto, dear colleagues, because of time limitation, so I do think we have to stop here. And I believe this webinar has achieved complete success and has proven highly productive and thought-provoking. And today we discussed complex calcium nodule PCI case and reviewed the draft of expert consensus on the management of calcium nodule and exchanged valuable insights and real-world practical experience on this critical topic. And I would like to extend our sincere gratitude to all experts for your constructive and in-depth comments regarding the expert consensus. And your valuable suggestion will be carefully incorporated, enabling us to further refine and enhance this consensus statements. And I also would like to express my heartfelt thanks to all speakers for their outstanding presentations and to every participant for your active engagement and continuous support. And really in the calcium nodule field, we lack of high quality evidence. We have much work to do, just like Professor Xiao said, like the registry study, etc. And as to the imaging tools, our team invent a system, we call it the COVID system. The system is based on AI technique and based on the CT angiography imaging, and we can reconstruct the 3D imaging of the calcium plaque. And I think next time we will show the experts and the audience the novel system. And in the future, we plan to host approximately 12 sessions of the ACE-PCI project annually. And we warmly invite all experts to take turns chairing and organizing future meetings. So like Professor Otto, Professor Yahya, Professor Xiao, Professor Dabbas, Professor Hamdan. So if you're interested in participating, please do not hesitate to contact me. And today's meeting has been a resounding success. We have fully achieved our core objectives of academic exchange and clinical experience sharing and consensus deliberation. Thank you once again for your participation and support. We look forward to welcoming to our upcoming session. Okay, thank you. Bye-bye.